Welcome back, coders. Man, I am absolutely thrilled to have you here for part 77 of our 100-part CPC exam series explainer. We're tackling one of the most heavily tested areas on the exam today. But before we crack the code on this one, make sure to like, share, and subscribe to Decode Healthcare with Harshal. Today, we are taking a laser-focused look at the 2026 E&M guidelines for office and outpatient services. Let's jump right in. So here's our game plan for today. We're going to run through the office and outpatient overview, tackle MDM to code mapping, dive into a time-based coding masterclass, break down the prolonged services rules, and wrap it all up with a slick EM summary cheat sheet. Let's get to it. Okay, let's dive into this, starting with a high-level view of the 99202 to 99215 code family. Now, right out of the gate, there is a massive exam trap you've got to avoid. When you're dealing with office and outpatient visits, your code selection is based strictly on either medical decision-making, which we all know as MDM, or total time. That's it. And hey, notice that 99201 is completely gone from the CPT code set, literally deleted. So new patient codes officially start at 99202 now. Oh, and keep in mind, 99211 is kind of its own beast. It's strictly for minimal clinical staff services, meaning it doesn't require MDM scoring, and it doesn't even need a physician's face-to-face presence. All right, moving right along to Section 2, MDM to code mapping, where we see how this all builds together. Take a look at how this breaks down. We've got new patients on the left, established patients on the right. Notice the time differences here? They are huge. For a straightforward MDM, a new patient gets a 99202, right? That represents 15 to 29 minutes. But an established patient with that same straightforward MDM gets a 99212, which is just 10 to 19 minutes. The exam loves to try and trip you up by mixing these two up. So you always want to double check if the patient is new or established before you apply that time range or MDM level. Trust me on that one. And this brilliantly illustrates the rule of two. This is our alternative to time-based coding, right? The actual MDM scoring. To hit a specific MDM level, you actually have to meet or exceed the requirements for 2 out of the 3 elements. That's your number and complexity of problems, the amount of data reviewed, and the risk of complications. Hit 2 of those 3, and you're golden. So, if you aren't using MDM, you're using time. Which brings us perfectly to Section 3, our time-based coding masterclass. This is a spot where a lot of CPC exam students unnecessarily lose points, so let's clear it up. According to the 2026 guidelines, total time is defined precisely as the cumulative time spent by the physician or qualified healthcare professional on the exact calendar date of the encounter. It includes both face-to-face and non-face-to-face work. The absolute key phrase here is exact date. Seriously, if the doctor reviews a chart the night before, guess what? That time does not count for today's code. It has to be the day of. Now, what's really interesting about this next part is the double dip rule. You absolutely cannot count time spent on separately billable services toward your EM total time. For example, if the provider bills separately for interpreting an EKG, you actually have to subtract the time they spent doing that interpretation from the total EM time. No double dipping allowed. Let's lock in exactly what counts versus what definitely doesn't. Prep time, history taking, counseling the patient or family, documenting in the EMR, communicating with other healthcare pros, all of that counts. But you've got to beware of the exam traps on the right. Clinical staff time never counts toward the provider's total time. Travel time? Also nope. Sadly, sitting in traffic, commuting to the clinic does not earn anyone RVUs. Teaching time is out, and, as we literally just discussed, time spent on separately billed procedures is completely off the table too. But what happens when a provider goes above and beyond the absolute maximum time threshold for the highest level visit? Well, that brings us to Section 4, Prolonged Services Rules. You can only use prolonged services if you follow these very specific steps. First off, the base code must be selected strictly on time, not MDM. And it has to be the highest level code, so either a 99205 or a 99215. Second, you have to actually meet or exceed the maximum time threshold for that specific code. Once you hit that wall, only then can you report an add-on prolonged service code for each additional 15-minute increment. So the crucial point here is knowing exactly which add-on code to use, because they are different. CPT code 99417 is your standard go-to add-on code for commercial payers. But if you're dealing with Medicare or CMS claims, you have to use the specific HCPCS code G2212. The exam absolutely loves testing to see if you know the difference between standard CPT rules and these Medicare-specific G codes, so you really want to keep this distinction sharp.
All right, let's bring this whole shebang together in Section 5 with our EM summary cheat sheet to lock this all in. Here is your visual EM powerhouse, perfect for a quick review. Let's recap. First, level your visits by MDM or total time. Second, remember 99201 is basically a ghost code now. Just ignore it. New patients always start at 99202. Third, 99211 is exclusively for clinical staff, no MDM needed. Fourth, total time means cumulative, same-day work only. Zero double dipping and absolutely no staff or travel time included. And finally, those prolonged codes, 99417 and G2212, they only unlock after you've totally maxed out a 99205 or 99215 based on time. And just like that, you are now armed with the exact logic you need to conquer the office and outpatient E&M section. But ask yourself this, if outpatient coding requires this crazy level of exact timing and MDM mapping, how dramatically do you think the rules shift the moment a patient is actually admitted to a hospital bed? Are you ready to master hospital inpatient and observation care, consultations, and the ED? The rules totally change in those settings, and we're going to decode every single one of them in Part 78. Until then, keep studying hard, and I'll catch you in the next explainer.